ladies and gentlemen. Welcome to another session of One-on-One with Dr. B. In today's session, we are going to be discussing preterm babies and all that you need to know about preterm babies. So if you missed our Zoom session on Friday, then this video is for you. Stay tuned and enjoy. Good morning, Dr. B.
Good morning, ladies, and thanks for having me.
You are most welcome. So today the topic is preterm babies. So I'll go right into the questions. What is a preterm baby?
All right, thank you again. When we say preterm or preterm babies, all that we are referring to is a baby that is born before the 37 weeks of gestation. Normally the pregnancy is supposed to last up to the 9th month, or if you want to use weeks, between the 37 weeks and 40 weeks. But for various reasons, some babies decide to come early. And so these are the babies that are termed as preterms. That is, they are born before 37-week gestation. Sometimes we also have some divisions or categorizations depending on the time. So for instance, we can have a baby that is born before 28 weeks, and those are the ones that we refer to as the extreme preterms. Okay, and so from between the 28 and 32 weeks, they are one that we refer to them as the very preterms, or the proper preterms, so to speak. And then from 32 weeks up to 36 weeks, 6 days, are the ones that we refer to as the late preterms, or if you like, the near-term babies. And so those are the subcategories or divisions that, and obviously these divisions are done to help you in your management, and then it also lets you know right from the onset what to expect, in terms of the challenges that this baby is likely to face going forward.
So what causes a baby to be born as a preterm baby?
Right, so I would rather put it this way. What could be some of the risk factors that can actually lead to a child being born preterm? Because causes per se, most of them they are spontaneous. It's like you can't pinpoint the reason why it happens, but rather there have been some risk factors that have been identified that when you find yourself in those risk factors, you are likely to deliver a preterm baby. For example, it is believed that extreme ages. So, for instance, if you are less than 80 years and you become pregnant, you stand the risk of getting or delivering a preterm baby. All right. Then it's also believed that if, let's say, you are 35 and above, all right, that means that can also be a serious risk factor for you to deliver a preterm baby. And these are all well documented statistics. And obviously, in the case of the above 35-year-old, it's probably because as we are aging, teens also tend to age in us, and so then those are some of the risks. And there's a likelihood that such an individual may also have an underlying condition like hypertension or diabetes, as against, let's say, a mother who is 20 years old. You get it? So as we age, we get a lot more risk in various other diseases. Then the other thing that is also a risk is, for instance, if you delivered and it's less than a year and you conceive again, you're also likely to deliver a preterm baby. And then also the flip side is that if you've delivered and you waited so long a time and it got to maybe after 60 months, after the previous child, that in itself is also a risk for you to have a preterm baby. And then we're also looking at, let's say, the baby as a factor So if you conceive or your pregnancy is twin, triplets, or quadruplets, quintuplets, because they are occupying a space that they are fighting for space, then the uterus becomes a bit of very, tense, and there's a likelihood that they want to come out before time. There is also a history of an individual or a mother who have had a preterm delivery before. If you had a preterm delivery before, you also stand a risk of giving birth to another preterm baby. And of course, for some people, it's as a result of some challenges that they may face as the organ, the uterus. Side effects of the uterus can also be a challenge. So, for instance, if you take a look at we call the cells or the mouth of the womb, right? If it's a short type, the likelihood that the baby will come out early is also there. And so, for some of those mothers, what they do, or when we say your uterus is your cervix is incompetent, it means that there's a likelihood that it almost always doesn't function as supposed to. And so once the uterus becomes a bit gravitous, or like there's pressure on it, and the mouth of the womb opens, then the baby can come out. So those are the ones that mostly, OBGYs will do the sacrilege to want to close the uterus or the mouth of the uterus so that baby doesn't come out. And that's quickly. Of course, there are some other, I mentioned it briefly, chronic diseases that can predispose you to delivering a preterm baby. Hypertension has been known for that, and diabetes is also known for that. And there are some more autoimmune diseases that your own body tends to attack your own body, so to speak. These are also diseases that can predispose a pregnant woman to deliver before time. As I was saying, with the hypertension, for instance, it is as a result of the hypertension that maybe a pregnancy will need to be terminated, because you have instances where the BP will go so high to the point that it will put both mother and baby at risk. For the preeclampsia state or the severe preeclampsia state, and if you are not careful, you have a convulsing pregnant woman on your hand, what we call the eclamptic state. So you would want to ensure that when you are pregnant and that is about happening, you will have to find a way of intervening. It also means that the preterm delivery can be spontaneous or as a result of a medical condition. All right. Then one other risk also is the fact that some mothers tend to pick infections during the pregnancy. That infection also can be a factor. So, for instance, the fluid in which the baby might be lying, or the amniotic fluid, can get an infection, and that can predispose the rupturing of the membrane easily, and then baby can also decide to come out earlier than usual. And so maybe there are lots more factors. So for instance, if you are abused of, which is not common in our part of the world, if you are abused of some hard drugs or the use of cigarettes, all those things can be factors that can actually predispose you. They are risks. They might not necessarily be the cause, but important risk that can make another deliver preterm.
Okay, could it be hereditary? Because I had this lady telling me that she had her first child and it was a preterm, and her mother had her too as preterm, and her grandmother had her mother. So I was wondering if
yes, so exactly, good. That is also important. There is that tendency that there could be a genetic component. All right. So it's also more of also a risk where the family line or family history of preterm deliveries. So in that case, yes, you are right. We've seen instances that also happens.
So, and what are the challenges a preterm goes through?
Right. So it means you want them to go into a NICU setting, right?
Yes.
Or places where we cater for them. So in fact, for the mothers out there, it's now quite comforting that there are a lot of centers around that are able to adequately cater for the preterms. I had the privilege to have worked in a setting where we managed to keep a 25-week-old, alive, and is now, I think now in the child's about 8 or 10 years old, and she's perfectly well. So that's tells us that there's help out there, and if we put our minds to it, we can do it together. So back to your question. Now, when let's say a preterm comes out, and as I indicated, it will depend on the gestational age. So we have the extreme preterms, we have the very preterms, and the near terms or the late preterms. Most of the time, the challenges that we tend to face are the ones that are the very preterms and then the extreme preterms. All right. So those ones would come with breathing challenges. Breathing challenges because before the 32nd week of pregnancy, there is a substance we call surfactant. It helps you mature your lungs, and when you come out, you're able to breathe well. So if you are born before the time that substance is formed, it means your breathing will automatically compromise. And that's why when people come to the medical setting, they are likely to see some of those preterms on oxygen. It's a way of supplementing or helping them breathe. In other conditions, there is a machine called a CPAP that we can actually use to help in the breathing of the child. In exceptional situations, which is quite rare nowadays, then you will need or you require the service of a ventilator to help the baby breathe. So breathing becomes a challenge. Now, two, they are very much prone to infections. Why? Because our body or the skin serves as a very, in fact, it's one of the best protective organs that we have, our skin. So because the preterm comes before time, normally some of them will have a challenge with, the skin tone or the nature of the skin is very light and fragile, and so it can easily be broken into. And so if something that is supposed to protect you is easily broken into, it means that you are very much prone to infection. Alright? And you also hear that mostly where these preterms are catered for, we tend to have a lot of instrumentation. We do a lot of IV cannulations, or we give them, some procedures. All these things tend to breach the sanity or the integrity of the skin. And so that can in itself also predispose them to a lot of infections. Alright? Not to talk of some of the, let's say when you do a cannula, alright? The cannula in itself can serve as a source of colonization for organisms to start growing, whilst it's in the hand or the legs or the head of the baby. Okay, so those are some of the things that predispose them to picking infection. They are also mostly exposed to or getting infection easily because they came before time, their immune system is compromised, it's not that developed. Alright? Babies in general have their immune system not developed, but maybe it's worse in the preterms because they came before time and their immune system is always like challenged. And so that can also predispose you. When any infection attacks you, you don't have the mechanism to fight back. And that is where it leads to they becoming so much prone to picking infection. One other challenge also that they tend to have mostly is the fact that they become anemic. They become anemic easily because when they are born, their blood level, what we call the HP, is so high. And then it starts breaking down so quickly. Alright? And when it breaks down so quickly and you don't do anything about it, if your HP is high and it starts breaking down, eventually it will get to a place where it gets depleted. And that's where the anemia sets in. But it also gets, it breaks down easily because of the fact that they are prone to infections, as I mentioned. If you are prone to infection, what the organisms do is that they attack your red blood cell muscle and it breaks you down. So for them, it even becomes a double kind of scenario where they pick infection easily, the red blood cells start breaking down easily, they become anemic. And they can also become very jaundiced easily because of the same scenario where because they are breaking their red blood cell, one of the components or maybe like byproducts of the broken down red blood cell is something called bilirubin, which is supposed to be eliminated through the gut, all right? And mostly preterms have challenges with their guts, and so we don't feed them immediately. So it means that the process of eliminating the bilirubin also becomes a compromised thing, and so then the bilirubin stays in their skin. They get it. So it's like all their problems tend to interlink. They are also very much prone to becoming hypothermic, and that's why when I say hypothermic, what I mean is that they can become cold easily, and that can lead to death. Why? Because when they are coming from the uterus is believed to be a very hot place. It's estimated that it's about 40 degrees. So when the baby comes out with a not so developed skin, and they don't have a substance we call brown fat, okay, so then because they don't have all these things developed, then you expose them to an environment which is cold, then they immediately turn into hypothermic state. And that's why mostly when they come out, you need to put them in incubator. That will mimic more or less the temperatures of the uterus to keep them going, or for them to understand that they are still in a setting that is still conducive for you. Alright. And so that is also one of the reasons why we use the incubators for them. And so the hypothermic state can also lead to hypoglycemia state, that is your sugar dropping. Because once you are hypothermic, you will need energy to fight back, alright, to generate heat. And so if you don't have adequate reserves of glucose, which most cases happens in the preterm, and it means that the little glucose that you have, you need to use it to fight the cold that you are facing. Okay, and that is why they tend to have hypoglycemia a lot. And it's one of the things that if you are not careful in the NICU setting can easily kill the preterm babies. In fact, there are a lot of challenges that they have, but I think these ones are the major ones that they tend to face.
The challenges are a lot.
Yeah.
So how do you manage them? In such a situation, you have this coming out, that coming out. How do you manage?
Okay, so good. Still in the NICU setting or the neonatal intensive care unit setting, because you know that these are the challenges that they are likely to face, you make provision for that. So for instance, as I mentioned, you want to put the child in a setting where the temperature should be adequate. In fact, we specifically have to tailor down the temperature based on the weight and gestational age of the preterm. Okay, that is done so that they will feel that well in that NICU setting. And for those that are likely to have the hypoglycemic state, we normally see that when you go there, you see them on some drips. Okay, and so then it means that it is maintaining more or less, or it's taking over their feeding. Okay, which is, I mean, these are in the early days of birth, maybe within the first mostly 5 days of birth. These are normally what we do to ensure that you have an amount of glucose at each time circulating in the child. All right, and then we also sometimes put them on antibiotics because of the fact that they are so much prone to the infection, and some of them actually do get the infection. So then we have to do antibiotics coverage. We also sometimes have to put them under a blue light, or we call it phototherapy unit, because they are so much prone to the jaundice. All right, so more or less, and of course I mentioned that we need to put them on oxygen support for those who don't breathe well, depending on the gestational age, and the fact that sometimes we have to step up to use a CPAP, all right, or eventually use a ventilator that would take over the breathing of the child, depending on the circumstance or the situation of the preterm. And so more or less, these are some of the things that we do for them in the early days of life. But going forward, of course, after everything is done and dusted, we might need to do their follow-ups. And that is where the real challenges happen, because preterms that they have, some of them are likely, I'm using my word advisedly, are likely to face, both mental and physical disabilities. And that's what the purpose of the follow-up is supposed to be for. Because you can just imagine somebody who was born with 0.5 kg or 900 grams. It's yes, to get the fellow to grow, to become normal and all this. It's a long process. It's not just a nickel thing. That's why we also have what we call the nickel clinics, where such babies are, taken through right from discharge through to probably when they turn to age 6.
So what can a mother do to help her child in such a situation? Because maybe your child is in nickel, you are doing all of these things. A mother will be worried. So what can she do to make the situation better?
Okay, so it's a good question you ask. Normally, what we try to do, and I'm very particular about that because it's only when the parents will understand what's happening that they can actually give you their full support. So as part of the management, it will get to a point that you may require breast milk from the mother to help you in managing the child. And so it will only be fair that right from the onset you explain things to the mothers, all right, and get them to know that a time will come that they may have full access to the child. And so when it gets to that point, yeah, right, we've seen instances where mothers, upon seeing their children for the first time, run away from the nipple setting, or break down crying, because especially for the first time it's a shocker. You've never seen things like that before, and so you have to talk to them, let them understand what they are in for. Mostly they buy into it, and they get to the point where they come on board and do wonders with the babies. So for instance, you've heard of the concept Kangaroo Concept. It's one of the things that we take them through, and it's very important. That's the concept for us to be able to let them understand what's happening, at what stage they will come in, and then when they are comfortable enough to discharge them. So for us, it's for instance a policy that until the mother is comfortable to want to discharge the baby home, you don't discharge them. And so sometimes it takes about a month for you to leave the child with them alone to do basically everything about the children or the preterm by the mother herself, whilst you assess. And once the babies and mother are comfortable, then you go ahead and discharge them.
So can you explain more about the kangaroo mother care?
Okay, so it's basically about the fact that the kangaroo has a very nice concept. It keeps its little ones in a kind of a pouch. Okay, so what this concept seeks to do is to find every available means for babies or the preterm baby in this instance to be mostly with the mother. And then the kangaroo, whilst the mother, the little one is in the pouch, does basically all the essential things in the pouch. Like keeping warmth, alright, ensuring adequate breathing, ensuring that the feeding happens. So it's the same concept. So what happens is that the baby is placed mostly in between the two breasts of the mother, alright, in a posture like a frog-like position, alright, so that at any given time, the child, and then this of course is covered, with adequate clothing. And then at any given time, we want to ensure that this baby has access to the breast, is having the adequate warmth from the mother's breast, because the breast is believed to generate a lot of heat, alright. And then also ensure that baby does all the essential needs there without having the need to move baby out of the pouch, or in this case, in between the breast of the mother. Okay. Then also it is very soothing, because you see, preterms as they are, one of the challenges they tend to have is what we call apnea attacks. So they can cease breathing for a period of about 5 seconds. But once they are in the mother's pouch, it is believed that the heartbeat of the mother tend to keep stimulating them so that they don't get into the state where they have, the apneic attacks or the cessation of breathing for a period. It can be very dangerous to them. You get it? And then also, it also helps them, feel protected. And so it is believed that, in fact, it's believed that the Kangaroo Concept tend to give very appropriate vital signs better than when they are in the incubator, because the bonding starts there and then. They know they are protected, they know they are in the mother's, so to speak, bosom. And so their breathing is adequate, their oxygen controls are better, and so on and so forth. So the Kangaroo Concept is very, very unique, it's very important, and that's what we normally introduce most of the mothers to.
So it's only between the mother and the baby, or the father can also do it?
Yes, so every family member at any point can join in, so that at least the mother can have other things doing, like if there's a need to go to a wash down, but that of other family members would be limited, or the baby will not benefit fully as much as, because for example, if it comes to breastfeeding, apart from the mother herself, nobody else can actually help in that regard. All right, but yes, when it comes to the warmth and the comfort and things like that, the babies can actually be kept by fathers. And so now even there is a debate out there whether the concept of kangaroo mother care should be changed into kangaroo parents care. All right.
And with the expression of breast milk, sometimes mothers express breast milk into feeding bottles, etc. for their baby. But in the case where these preterm children are very delicate, is it sanitary enough for them to do that?
Yes, the point is that, yeah, right. I mean, it depends on who is doing what. All right. The only care that we all have to ensure is that those expressions are done under very hygienic conditions, and then ensure that whichever containers they are going to use are also hygienic enough or very sterile enough. But otherwise, yes, as I indicated, for the care of the newborns or the preterms in the NICU setting, sometimes the parents have to express the breast milk for us to keep for them and be given us and when it is required. We don't normally allow them to stay with the children in the NICU setting. Unless of course they are coming to do work or the KMC, in which case it's also done in a certain portion. You understand? And so yes, so the expression that is done, and it's done for the preterms, and we make use of different. But of course there are some type of feeding bottles, we call them the orthodontic. The teething is quite soft and smaller, so sometimes that is what we recommend to be used for the preterms, because then they are able to tolerate it better as compared to the normal one that other bigger babies use. This one is tailored for the small mouth of the preterm, so to speak.
So in the home setting now, you've been able to take care of the child in the NICU setting, they've been discharged. In the home setting, what must the mother do to ensure the proper growth of the child?
Okay, so as I indicated, we don't just discharge them and leave them. And then we also discharge when they are not comfortable. I mentioned that they will have to stay with us for quite a time, that we will assess and be sure that this baby and mother are good enough to be sent home. In fact, in some settings, we ensure that they attain a certain weight before they are sent home. So all these things are measures to ensure that when they go home, they will be comfortable. All right, but I mean, just like any other baby, you want to ensure that the baby is in a clean environment. They aren't, ingenious substances around them, or very scented things, or dusty environment, or excessive use of detergents and scented products and things like that. I mean, a very clean environment in the home setting is what we always require. But as I also said, it will depend on the weight at birth of the preterm. We normally want to see them, some of them every 2 weeks, some of them every 4 weeks. Depends. And so those kind of follow-ups are tailored to ensure that at any given stage, the baby is in the right, development stage and is being catered for well.
Is there any other thing you want to add?
So probably I would want to say that because this is some of the challenges sometimes we face with some employers. So some employers are so keen in getting their employees back to work to the extent that sometimes it affects some of these preterms. So maybe the little request that I would want to make is that when such mothers are their employees, they should understand that those babies need special care, and that probably if you expect them to come back to work after the mandatory is it 90 days of maternity leave, and they extend beyond that, we should be able to understand because it is for the good of the preterm. They are not like the normal term babies. Their needs are different, their care is different, and so some of those employees should be able to look at it from that perspective and then allow the mothers some space to cater for their preterms, because after all we say the future of the nation belongs to the children.
Yeah. Okay. Thank you very much, Dr.
Thank you for having me, and you're always welcome.
It has been a very educative session. Yes. And so, viewers, we hope you enjoyed this session and you learned a lot of lessons. So make sure you like, you comment, subscribe to our channel, and you share this video. See you in our next video.